But really just to talk about kyphosis in and of itself and how management of TGR can help or hurt you. So there's lots of papers that we all understand inherently. It's like we feel it in our heart that kyphosis is a problem, right? It's one of our big problems. There's plenty of proof. It makes perfect sense, right? Because we're really behind the axis of what we're trying to do, and unless you come up with a really good way to lengthen the patient through their sternum, you're going to be fighting this with any kind of posterior-based instrumentation, particularly traditional growing rods, which are a distraction-based posterior instrumentation system. So there's plenty of proof in the literature that thoracic kyphosis is one of the risk factors for complications. This study, 3 times more likely to experience a complication than those that had kyphosis in the normal range, and it's a linear relationship for all complications. In this study, the complication rate, again, is higher for the hyperkyphotic group than for the normal kyphotic group. Ron had a study looking at risk factors for PJK, which again, I'm not going to talk too much about specifically PJK, but for sure a higher preoperative thoracic kyphosis and also higher pelvic incidence. And then there's this general study by Russo this year that showed that, again, hyperkyphosis patients at least 2 times as likely to have complications, although they couldn't delineate a clear relationship between anything in particular in that group and ICEOS and Smith complications. And finally, this study that showed that there were 110 patients treated with traditional growing rods, and preoperative thoracic kyphosis, again, was a risk factor for complications. So that's understood. How can we try to approach it? And when I think about that, I try to think about all the things we could possibly do preoperatively to try to fight this. Halogravity traction, I'm going to talk about a little bit. Intraoperative positioning can help. Really, we don't have that much data about that. Rod selection and contouring, we have very little data on in early onset scoliosis, really with any of our constructs, and that probably invites an area for study. Implant type, I'll talk about what we know about that. Staging the procedure, whether or not that may or may not help. And again, no data about whether immobilization postoperatively can help prevent problems. So halogravity traction, there was this study this year looking at sort of our state of our best practice guidelines and came up with these things, which include traction for kyphosis of greater than 90 degrees, look at their C-spine and MRI preoperatively, low pressure on the pins, aim for 50% body weight. 2 to 4 weeks is probably appropriate in our world, at least in North America, and most of the correction probably occurs in the first 2 to 3 weeks. And make sure you do a daily neurologic examination. So any patient that you're trying to fight the kyphosis with the traction needs that daily exam by your team, not just by the nurses. In other parts of the world, they can use traction for as long as 202 days in one of Boachi's studies recently. And this was specifically on early onset scoliosis patients. They saw an improvement for sure in the kyphosis from an average of 62 to 40 degrees, so helpful. We can't realistically in most of our hospitals keep patients in-house for 202 days, but we certainly can keep them for 2 to 3 weeks. This was just a final study looking at the effect of growing rods on sort of sagittal plane parameters, and they showed hardware complications in a ton of them. They showed thoracic kyphosis was somewhat corrected using this traditional growing rod technique. Ron's going to talk about magnetic control growing rods, but maybe traditional growing rods are a little bit better in some circumstances than MCGR because we don't have quite as long a flat area. And I'll talk a little bit about the effect of the connectors. Positioning, this is about all we can do, I think, is keep the chest support high and try to keep the hips extended to add lordosis where you can. Rod contouring, adding kyphosis to the proximal end, again, that's sort of what we all understand to do. We feel like that's going to decrease the risk of PJK when we're treating the hyperkyphotic patient with traditional growing rods. How stiff should the rod be? Really not clear. There's some good data in adults that stiffer constructs are associated with more complications, both in hyperkyphotic and normal kyphotic patients. Maybe not so much in the early onset patients. This study showed some interesting mechanical testing this year from the FDA. And again, more rigid crosslinks, however you make them more rigid, were associated with increased mechanical failure. And it makes sense that that would be more true in a hyperkyphotic setting. What type of connector? Can you help yourself any with what type of connector you use if you're using TGR? Maybe. Matt Otchin did a good study looking at wedding bands versus tandem connectors and showed that although the overall kyphosis control was similar, there was a trend towards better maintenance of kyphosis with the wedding bands. So that intuitively means you have a shorter connector. You don't have a tandem long connector, similar to what you have in the Magic Rod, and that may be protective. What kind of anchors should you use? Will that help you with a kyphotic patient? Probably not. No evidence that we have. There's some good studies comparing proximal rib versus spine anchors showing similar rates of control of kyphosis and similar rates of failure. Again, this study looked at comparison of growing spinal implants and showed about a 73% complication rate for all comers and really not a big difference. So whether you're a rib person or a spine person probably isn't going to make any appreciable difference for these constructs. And finally, will it help you to stage the hyperkyphotic patient? Again, maybe. This was a study that Reinhard Zeller's group did where they looked at 15 patients where they did stage procedures. They actually used haloskeletal traction on the table, and in addition, they used some halogravity traction. And they didn't have a very high incidence of PJK by comparison, and they also had a slightly lower complication rate overall. These patients weren't specifically all hyperkyphotic, but many of them, as you can see from a couple of these examples from that paper, were hyperkyphotic. So this is maybe something to think about. If we set up our anchors and let them sit for a little bit before we start pushing and distracting, is that going to help us in these settings? I think it might. I don't have experience with it. So now we'll talk about MCGR.